ಬಹು ಅಂಗಾಂಗ ಗಟ್ಟಿಗೊಳಿಸುವಿಕೆ ರೋಗಗಳು ಹಾಗೂ ಭವಿಷ್ಯದ ಸವಾಲುಗಳ ಕುರಿತಾದ ಕಾರ್ಯಾಗಾರ ನಿಟ್ಟೆ ಪರಿಗಣಿತ ವಿಶ್ವವಿದ್ಯಾಲಯ ಅಧೀನದ ಕ್ಷೇಮ ಮೆಡಿಕಲ್ ಅಕಾಡೆಮಿಯ ಚಿಂತನ ಸಭಾಂಗಣದಲ್ಲಿ ನಡೆಯಿತು.
ಯುನೈಟೆಡ್ ಕಿಂಗ್ಡಮ್ ವೇಲ್ಸ್ನ ಕಾರ್ಡಿಫ್ ವಿಶ್ವವಿದ್ಯಾಲಯದ ನ್ಯೂರಾಲಜಿ ವಿಭಾಗದ ಪ್ರೊಫೆಸರ್ ನೀಲ್ ರಾಬರ್ಟ್ಸನ್ ಕಾರ್ಯಾಗಾರದ ಸಂಪನ್ಮೂಲ ವ್ಯಕ್ತಿಯಾಗಿ ಭಾಗವಹಿಸಿ ಮಾತನಾಡಿ, ವೇಲ್ಸ್ನ ಕುರಿತಾಗಿ ಪ್ರಾತ್ಯಕ್ಷಿತೆ ನೀಡಿದ ಅವರು, ಪ್ರಪಂಚದ ಬೇರೆ ಬೇರೆ ಭಾಗದಲ್ಲಿ ವಿವಿಧ ಕಾರಣದಿಂದ ಈ ರೋಗಕ್ಕೆ ಪ್ರತಿ 5 ನಿಮಿಷಕ್ಕೆ ಒಬ್ಬ ಚಿಕಿತ್ಸೆಗೆ ಒಳಗಾಗುತ್ತಿದ್ದಾನೆ. ರೋಗಲಕ್ಷಣಗಳು, ತೀವ್ರತೆ ಮತ್ತು ರೋಗಬಾಧೆಯ ಅವಧಿಯು ವ್ಯಕ್ತಿಯಿಂದ ವ್ಯಕ್ತಿಗೆ ಬದಲಾಗಬಹುದು. ಆದರೆ ಕೆಲವರು ತೀವ್ರವಾದ ದೀರ್ಘಕಾಲದ ರೋಗಲಕ್ಷಣಗಳನ್ನು ಹೊಂದಿರಬಹುದು. ಅದು ವಾಸಿಯಾಗುವಂತೆ ಮುನ್ನೆಚ್ಚರಿಕೆ ವಹಿಸಬೇಕಿದೆ ಎಂದು ಹೇಳಿದರು.
A country or even globally. And we need to understand the influences that allow us to do that are probably beyond our direct influence seeing people in clinics. And as such, we need to look for global organisations. And one of the global organisations, amongst a few others, that have had a really quite profound impact on multiple sclerosis is the MS International Federation. And that's a global network of all the 47 MS organisations that are currently seen. And their mission, as it were, is to strengthen and support by sharing expertise and resources, by championing and campaigning for increased awareness of MS. And I'll go on to say why I think that's so important. I mean, you've heard a little bit from that, why that's important as well. To provide information for clinicians and for patients and for their carers, and to support international research into better treatments and ways of managing multiple sclerosis. So what is the Atlas of MS? So the Atlas of MS is a project within the MSIF which looks for global epidemiological data and is designed to produce a compendium of data which will provide information for political lobbying and pressure. And what it is a regional expert data collection. And I guess if we were to be hypercritical, that's its main problem, in the sense that it is not based on what we would consider a robust academic epidemiological studies, but information sometimes with the backup of epidemiological studies, which are channeled through experts. We've used this data to produce epidemiological information, to produce information about clinical management, some of which again you've heard from Nitte, and it continues to be updated every year. So every year we have this kind of diverse compendium of data which allows us to have a global view of MS. So you can look all this up. So there's an interactive website which gives epidemiological data for each country, and you can find the website and you can hover your pointer over the country of interest and you can find the epidemiological data relating to that country. So you've heard that there are 150,000 people, at least I should say, a minimum prevalence of 150,000 people with MS in India. But the compendium of data covers nearly 90% of the world's population. So it's a powerful data resource. It's incredibly well referenced in papers. In fact, I think it's actually my highest referenced paper that I've read. And these are a few key highlights from the 3rd edition. So just for those of you to reiterate that point, that if you think this is a small disease, this is a big disease, and so there are nearly 3 million people in the world with multiple sclerosis now, and the prevalence keeps on rising. And the reasons for that are complicated. People are living longer. There's probably earlier diagnosis. There is better access to technology, including MRI scans, but overall the prevalence, the frequency of disease is still increasing considerably. And it's probably increasing quicker in the lower and middle income countries than it is in the higher income countries, where it seems to have reached a relative peak. And also the epidemiology now focuses on incidence, so you need to know that every 5 minutes in the world somebody's diagnosed with multiple sclerosis. And again, that's increasing. So one of the barriers going forward to the diagnosis of multiple sclerosis, and this was important, you may think that, we may think that may have ideas about why there are global barriers, but the biggest global barrier is that patients don't recognise symptoms, that there's no understanding or knowledge of the disease. And also there's very little knowledge, this is globally, amongst doctors in terms of identifying symptoms that are relevant to multiple sclerosis. So it may be different in India, but for instance in the UK, if a 30-year-old woman turns up with a progressive hemiplegia over 3 days, statistically that's much more likely to be demand-making disease than it is to be any other disease. And so we have developed a knowledge of it. We need to spread that knowledge and make sure that people understand what the disease is, how it presents, and importantly that there are now things that we can do about it that are effective, but as we'll come on to later, they are critically time dependent. So where I work is in South Wales, and South Wales is the land of castles, steel and rugby. So the religion very much in Wales is rugby, this rather bizarre game where people beat each other up for 90 minutes on the pitch. And they have a cathedral, which I'll show you in a minute, for their religion. But Wales was very important in the Industrial Revolution. It was the centre of the Industrial Revolution in the UK. And at one stage it produced 2/3 of the steel in the world. And since that time we've rather ceded that priority to other things. And Wales is the bit that hangs off the end of the west coast of the UK, and its population is largely concentrated in the southeast around two cities of Cardiff and Swansea, but it has a large rural population which we also have to look after as well. Cardiff has metamorphosed into a modern, thriving city, and this is the on the left picture is the University Hospital of Wales. It's a big hospital, it has about 1,500 beds, and I live right at the front in one of those tower blocks, but it's a huge facility which looks after almost the entire population. And on the right of that picture, as you can see, that's the cathedral to rugby, which is called the Millennium Stadium, which is very important for Welsh, although they're not doing very well at that. So this is the parallel, really, with the Mangalore registry. Why it's actually been interesting to look at something that does almost the exact same thing. Numbers and frequency of diseases are a little bit different, but the basis is the same. Like Leper, we've had to develop structures which can contain our research, and the structures are the Helen Durham Centre, which was named after the lady who died very quickly at the young age of multiple sclerosis. The Welsh Neuroscience Research Tissue Bank, which is a tissue bank which we collect a large number of samples. We give samples out all over the UK and all over the world, which has really enhanced our collaborative ability, something which I think is more difficult to do in India. And we've abandoned handwritten notes, and we have electronic medical records, which is really effective, and it's going to come. You are going to be using electronic medical records, and our overarching ethical framework is something called Snowdonia, which looks after all of the neuroinflammatory patients, or allows them access to research. And so 75% of our prevalent population are signed up for research. So they're very research active, research enthusiastic individuals. And Snowdonia is a big mountain in North Wales. So we've had these data, we started in 1985, actually before my time, by a rather famous neurologist called Professor Alison Thompson. And he did a couple of cross-sectional prevalence studies. And really since 1999, we've effectively and systematically detected every referral that's come to us. We get about, and we do this through a central and regional clinic network, and we make about 100 to 150 new diagnoses a year from our making diseases of one type or another. We'll see probably twice that number to tell them they don't have that, but we make around 100 to 150 diagnoses a year. So we have a 97% case capture, so it's population based. So again, it's slightly different because people don't come from long distances to see us generally, apart from second opinions. but we know all the patients who have MS-related disease in our catchment area of around 1.5 million. And we follow them all up, so we perform an annual assessment, which clinical assessment on them, which means that there are about 60,000 assessments in our kind of data bank.
ಕ್ಷೇಮ ಡೀನ್ ಪ್ರೊಫೆಸರ್ ಪಿಎಸ್ ಪ್ರಕಾಶ್ ಕಾರ್ಯಕ್ರಮದ ಅಧ್ಯಕ್ಷತೆ ವಹಿಸಿದ್ರು.
It's a rare disease of a tropical disease, but Dr. Lekha and her team has sensitized us enough to say that it's not an uncommon disease, though we can't call it still common, not an uncommon disease, and possibly we should be looking out for these, particularly the ophthalmologists, the pediatricians, and the physicians. Look out for early, look out for the signs and possibly early referral, and using the services of our neurological department. Interventions can possibly, as Professor Robertson said, an early intervention during the window period can have a better outcome. Otherwise, as all of us know, hematology disease itself is a very heterogeneous group of disease where multiple sclerosis is quite common. And the thing about this disease is exacerbations, remissions, and every exacerbation leaves its mark. Ultimately, it may not kill an individual immediately, but cripples. And over a period of time, not only the patient suffers because of the quality of life, the caregivers also gets affected. So we definitely, and look at the population difference. Young, very productive age group, and also young caregivers. So we need to look. Right now, we have early therapeutic interventions designed. Of course, it should be much more cost effective. We need to have possibly biomarkers, early detection biomarkers, markers for exacerbations, early detection of exacerbations, so that we can keep the disease under remissions, have a few exacerbations, thereby we decrease the incidence of the disease. Sorry, not the incidence, the going into crippling stage. Of course, the treatment or the management of multiple sclerosis is a multimodality specialty wherein ophthalmologists, neurologists, physiotherapy departments, all needs to get in, and also the counselors, because whenever a disease has this type of manifestation, along patience is required on the part of the patient, the caregivers also. And of course, we know that it's an autoimmune disease. Whenever there's an autoimmune disease, the three important factors that come into play is the genetic factor. Right now, of course, some HLA system is involved, but we don't have a definite answer for that yet. The environmental factor, possibly so many implications are done, definitive answers are yet to be found. And immune system somehow going haywire. And once it starts initiating, what triggers of the recurrences, we just still don't know. The disease burden, particularly in a resource-constrained countries like ours, takes a heavy toll. And I'm sure Professor Lekha has her own come out with some novel diagnostic tool. And in this I see a future when the team from UK, that's Professor Robertson and Professor Lekha, work together and take this, find a way of cheaper investigations and also therapeutic interventions. So I'm very proud to be associated here to preside over this function. I thank the organizers. I thank Dr. Robertson, Professor Robertson, and also his wife, Mrs. Robertson, for having come all the way from UK and spent your precious time with us, enlightening us, and I'm sure we all go a little more enlightened about this demand, this disease.
ಪ್ರೊಫೆಸರ್ ಹರ್ಷ ಹಾಲಹಳ್ಳಿ ಪ್ರಾಸ್ತಾವಿಕ ಮಾತುಗಳನ್ನಾಡಿದರು.
Of course, along with Professor Robertson, we have as a bonus Mrs. Claire Robertson, interacting with our physiotherapy students and faculty, and being a neurophysiotherapist with immense experience, I'm sure that will also add great value to our faculty and students here. The Center for Advanced Neurosciences Research is a rare special unit of the university. It is a model for successfully combining patient services with research. Dr. Nitte is an uncommon example. Dr. Nitte, who leads that center, is an uncommon example of a clinician who has combined research, a clinician scientist who has demonstrated that research and patient services can indeed go hand in hand. As a devoted clinician, much sought after clinician, she has in fact shown that research need not hinder or come in the way of clinical services, but in fact can enhance patient care when it's a well thought out and well executed research program. And I'm sure that Professor Robertson, who is also a similar successful clinician researcher, will inspire many of our faculty and researchers to follow in these footsteps. As a university, we need to integrate clinical training, academic research, and patient services. I'm sure Dr. Prakash Dean will agree that as a university, unlike regular service institutions, we have these additional responsibilities of training and academic research. And I think we need to inculcate the spirit shown by our Center of Neurosciences Research here and Professor Robertson's unit in Cardiff as how this can be done successfully, how the apparently different aspects of patient services and research and training can in fact be brought together in mutually beneficial ways. I'm glad that as we celebrate the Silver Jubilee year of the medical school, Professor Robertson, for information, this is the 25th year of the medical school of the university. We are glad to host international experts like the two of you, with whom I'm sure that we can learn together and can collaborate and grow together.
What we have done using the example of our registry, which is for a very nice acronym, MANDIR, and this is our story. So you may ask, why tell us your sad story? We don't really need to know about it, but surely you need to, because there is a global increase in prevalence of autoimmune disorders worldwide. Even in countries where the prevalence has been studied meticulously, there's definitely over the decades a genuine increase. And it's not just because we have more MRIs and more neurologists in our part of the world. There has to be a general increase in the numbers of patients that we see, and that is also reflected in the number of patients I see in my practice. And also you should understand there's a significant skew in the ratio between women and men affected. Predominantly affects women and young girls, so much so that in the USA they say autoimmune disorders constitute one of the 10 most important causes of morbidity and death among women and young girl children. So that is the significance of this disease. And if you look at the, those who are skeptical, if you look at the overall prevalence of disease, that is for MS, 2 decades ago we didn't believe that we had MS. It was reluctantly reported of having a prevalence of less than 1 per 100,000. Now we know more indirect mapping of the global prevalence suggests that we have easily gone into at least a median prevalence of up to 20 to 30 per 100,000. If you look at the slide below, this is a reflection of the prevalence of SLE, systemic lupus erythematosus, which shares almost the same prevalence globally as does MS. And so you can imagine rheumatoid arthritis, Sjogren's syndrome, conditions that you name, recognize, have more or less similar frequency and prevalence, and you can add up the cumulative number of autoimmune diseases that exist in our country of 1.4 billion people, and you will realize how significant the actual prevalence of autoimmune diseases is. And so we have shown that, and so also very, very good and large publications from the West, that autoimmune diseases coexist, and we have found the same. So I'm not surprised when I see a patient with autoimmune thyroiditis, and my friends who are sitting here, the endocrinologists, the skin specialists, will see psoriasis, vitiligo. My respiratory colleagues will see a variety of autoimmune atopic conditions coexisting with disease. And the very next following week, I'm seeing a patient who has a regional uveitis, Crohn's disease, recognized by our gastroenterologist specialist, who also has MS. So that is to understand. So, unfortunately, the impact of the disease is not felt because we all live in compartmentalized little bubbles. We seldom interact. My rheumatology friends and I have common cases that we treat. So it's very important to note that there is a huge impact of this disease on the community. So the skewed ratios worldwide, when you look at different diseases, which includes also India, you can see systemic diseases, multiple sclerosis, you name it, they all have a predominant female preponderance. And in our part of the world, that creates a great problem, that you know that attitude towards children with the disease is more favorable towards the male of the family. And in terms of spending money lifelong on a patient's health, it's likely that the male of the family would get preference. So therefore, there are many ways we are disadvantaged as a consequence of the skew, and that we face during treatment decisions being made for these patients. So the clinical challenges are many. We have to show, when I started 25 years plus ago, my greatest problem was that trying to show that this is not some exotic disease seen in patients or people of European descent. And that was one of the biggest challenges, because people never took us seriously when we said that there are real cases that we see and that they are amenable to treatments. So we had to understand, in order to provide credibility for this disease in our part of the world, I understood that we need to show the burden of disease in our country. We had to understand if it's lesser prevalent, is it any way different from those seen among white populations. We have to find out how do you differentiate these demyelinating disorders, but because unlike the common thought, it's not a homogeneous disorder. There are very many autoimmune disorders which superficially mimic each other and lead to a huge burden in terms of diagnostic challenges. And then finally, how do you treat Indian patients who find imported medications unaffordable? So I like to think that we made a dent into all of these aspirations over the years. So in a single page, I would show you what I could do in 25 years. So we established the first population-based prevalence of the disease in India, and it's approximately at least 20 per 100,000. In a billion people, 1.4 billion, approximately at least 150,000 patients with MS. You would have a similar number with SLE, rheumatoid arthritis, Sjogren's, you name it. So therefore, the cumulative presence of autoimmune disease in the community is definitely, this is a very modest estimation that I'm making.
ಕಾರ್ಯಕ್ರಮದಲ್ಲಿ ಕ್ಲೇರಾ ರಾಬರ್ಟ್ಸನ್, ಕ್ಷೇಮ ಸೆಂಟರ್ ಫಾರ್ ಅಡ್ವಾನ್ಸ್ಡ್ ನ್ಯೂಮರಾಲಜಿಕಲ್ ಸೈನ್ಸಸ್ ನಿರ್ದೇಶಕಿ ಡಾಕ್ಟರ್ ಲೇಖಾ ಪಂಡಿತ್, ಡಾಕ್ಟರ್ ಸುಮನ್ ಉಪಸ್ಥಿತರಿದ್ದರು. ಆರಿಫ್ ಕಲ್ಕಟ್ಟ, ವಿ4 ನ್ಯೂಸ್, ದೇರಳಕಟ್ಟೆ.